Welcome. I'm Michael Parks. I am a hip and knee surgeon here at the Hospital for Special Surgery. My special interest is in joint replacement, and I specialize in putting in hips and knees into patients, particularly with arthritis, but particularly other maladies as well.
I'm Jose Rodriguez, also an attending here at the Hospital for Special Surgery, and Michael and I share a passion for taking care of these patients with hip and knee maladies.
We're here today really to discuss what is minimally invasive joint replacement of the knee. People come in all the time and they have problems, they can barely walk, and they say, oh yeah, by the way, you're going to do this minimally invasive, right? So we'd like to take a little bit of time and discuss what is minimally invasive replacement, joint replacement, and how does it affect your outcome?
So minimally invasive surgery of the knee is not just an operation, it's an approach to the patient. The goal is to literally minimally invade their body and their life with what we do. For example, it starts before the surgery, making sure that the patient is as healthy as they can be beforehand. To make sure that the patient understands that they are engaged in the process of making themselves better from the beginning until the end.
Yeah, and that process really is very important. We look at the patient and we educate you, your expectations. If you think you're going to be in bed for a week, well, that's not going to help you. We want you to know that this is going to be a process of getting you back to what you want to do, and that starts beforehand. It continues in the hospital. We use smaller incisions than we used in the past. In the past, we used to say big surgery, big incisions. Now we use smaller incisions. But it's not just the incision. It's how we approach the knee. Many of you are probably on the internet. You see that whether we cut muscles, whether we don't cut muscles, all of those fall under the umbrella of minimally invasive surgery. We're still doing small things in a smaller way, but we want to do them in an appropriate way. And we're managing patients, your pain, your nausea. We're proactively working with you to make sure you're comfortable and we can get you moving ahead. All of this goes on in the operating room, not just making a smaller incision.
Part of how we approach the patient is to minimize how we change their life. For example, when we first started, we were routinely transfusing patients, and we have learned both through how we do our surgery and through pharmacological techniques like a medicine called tranexamic acid, which has allowed us to transfuse less than 5% of patients, and all of them are predictable based on their degree of anemia before the surgery. So we know, for example, that the likelihood of me transfusing someone is directly related to how they come to surgery. In addition, before the surgery, preparing the skin, we engage the patient to prepare their own skin with a material called chlorhexidine, which kills the bacteria the night before the surgery. The patient is involved from the beginning of the surgical planning in making themselves better.
So some of the other things that we do surrounding surgery. Pain management. All of us are aware of the opioid crisis. We want to manage your pain, so we're not just giving you actively pain medicines, but we're doing other things. Some of them are the type of anesthesia that we use. We do blocks, which are basically where the anesthesiologist will numb a certain area of your body, and that will augment your anesthesia, rather than the old-fashioned general anesthesia where you go to sleep. And many patients who have that wake up, they're sick, they're nauseated afterwards. We use a regional anesthesia, epidural anesthesia, which is what most women use for childbirth. That's augmented by a process where they give you a sedative, the same thing you'll use for those of you who've had colonoscopies. You go to sleep, you wake up, you have this regional anesthesia, this block. It's all about comfort. Why is that important? Patients who are comfortable, who come out of surgery, they're ready to do well. They're ready to get up. They're ready to start on their road to recovery. And all of this is about your early recovery. And that's really what minimally invasive surgery is, getting you back to what you want to do faster and more comfortably.
You know, Michael, I would suggest that that's the most important aspect of minimally invasive surgical concepts, is getting the patient back. And the medications that we inject into the knees, the blocks that the anesthesiologist injects around the knee, allows them to have a day or two with very little pain. so that the very first day they straighten and bend their knee of their own volition and realize that they can, becoming an active part in what we call the importance of their recovery.
Yeah.
Next, in terms of doing the actual surgery, there is no question that if we can do it with cutting less unnecessary tissue, it's better. We will only cut the tissue that we need to do our surgery well and in a reproducible fashion. And that has really helped what we do in surgery. Beyond that, and probably equally important, is precision. Now, there are new ways that we are investigating here at the Hospital for Special Surgery to create precision in what we do. One of them is something called a handheld navigation device. Two of our surgeons, Dr. Ed Su and Dr. David Mayman, have been pioneering the research to understand how this affects patients' function. Do you find that useful?
I find it useful. I think that what people ought to understand is a well-done total knee replacement is based on just the foundation of how all of this is done. So I think that people that are doing a high volume of knee replacements, as we do here, they probably are ahead of the game. But then you can tweak these things. So whether you're going to use a robot or a handheld device or a navigation device or some of the newer things that we might describe, they're bonuses. But I think that the foundation of a good outcome is just good surgical technique.
We agree. One of the things that we do at Special Surgery, however, is to research these things, to not only do them, but understand how it affects your life. One of the things that Michael mentioned was computer-aided or robotic surgery. One of our surgeons, Seth Jarabek, is also researching how this can affect what we do. One of the things that we learned is how to feel the tissues so that we can translate our feeling of the tissue to what the patient feels. Using the robot may help us get that better. I'm not sure, but we're researching it and trying to understand it.
Yeah. We want to understand how it's not just cutting bones, putting in a prosthesis, but there are many things. We want to have those tissues at the right tension. We want to align your knee, not have you with many deformities where the knee is pointing one way or the other, and we want to have you able to bend and to get back to where you were previously or where you want to be. And that's really the end result of all of this. I think, so minimally invasive surgery is probably an end to our means of getting you back faster.
Michael, what do you expect a patient having knee replacement to do the day after surgery?
So it's interesting. I think that partly people have to look at where they are. So let's just say the average normal person, maybe 40 to 50 years old, who's very active, athletic, a golfer. Many of those people, if we keep them comfortable and we do this nice surgical approach, they'll get up that day of surgery. I tell them, they'll get up, they'll walk, whether it's 25 feet, 30 feet. I'm often not surprised. But if you are someone who's older, more debilitated, and you come in a wheelchair, you shouldn't feel discouraged because you haven't walked down the hall the first day. I often remind people that you took a while to get that debilitated, and it may take a while to get back. So part of your recovery needs to be gauged on where you start out. But for the average person who's very healthy and doesn't have other medical issues, it's not uncommon for them to get up, to walk, and here we're very proactive with that. So again, getting back to our theme on minimally invasive surgery, the day of surgery, our goal is to get people up. The next day, we want to get them up 3 times, and most of our patients are discharged home on the second day. I think we have a question from our audience.
Yes, Liz would like to know, how long is the surgery? So if you're looking for minimally invasive surgery, how long is that?
So surgery generally, I tell people it takes about an hour and a half. And I always remind everyone that neither one of us works on a clock. So we don't just stop at an hour and a half and say we're done, okay? But during that hour and a half, you have to realize there are several things that are happening. There are people that are getting you ready, positioning you, bringing you in the room. The anesthesiologist is doing your anesthesia, putting in the block. People are cleaning you off. The surgeon, our part of the surgery may be 50 minutes of that. But then there's putting on dressings, waking you up, making sure you're safe, getting you to the recovery room. So all of that comprises an hour and a half. That doesn't necessarily mean that you're under the knife or fully under during that hour and a half. But It's a process where we all work together as a team to get you in and out of the operating room.
Hour and a half being an average. In some people it's an hour, in some people it's 2.5 hours, depending on the anatomic constraints that we have to deal with.
We also have another question. Monique would like to know, who is a good candidate for minimally invasive surgery?
That's a great question. So I want to just comment on what Dr. Rodriguez just said. So Jose said an hour and a half depending on who you are. So if you come with a really, really deformed knee, maybe you had a fracture when you were 16 and your knee is just terribly deformed, maybe that's going to be a little longer than an hour and a half. And you probably are not going to have the smallest incision, because our number one goal is to do good surgery and to get you a good outcome, and that may not be through the smallest incision. But people who have minimal deformity, people who have normal size. So I also operate on people who vary a lot in weight. We all do. So if you happen to be a larger person, you may not be a candidate for a small incision. But having said that, many of the things that we talked about, we're still going to do that are advances for minimally invasive surgery. We're still going to control your pain. We're still going to cut the minimal amount of tissue that we need to. We're still going to be proactive in getting you up and moving you around. Do you have any other thoughts on that?
I 100% agree. The less deformity you have, the closer we can come to reproducing what was the normal anatomy of your knee, which is where your soft tissues are going to be happiest, and that's our goal. With greater deformities, we have to do more things to get closer to that.
We have another question. Rita would like to know, can this be done on patients with rheumatoid or psoriatic arthritis?
Absolutely. So people with rheumatoid or psoriatic arthritis, again, their end is the same. So whether it's osteoarthritis or an inflammatory arthritis where the body attacks the cartilage, the problem is arthritis, where there is bone on bone or bone rubbing against bone, and that is ultimately the cause of pain. Kind of a final common pathway. Unless there's a large amount of deformity or bone loss or your knee is really deformed, then we can do these. Or if your body size, you're a really big person or a really small person, that makes a difference in whether we can do it. But if there's just a normal person, the disease process itself doesn't preclude that.
There are some disease processes that actually affect the vascularity to the skin. And on those patients, making a bigger incision is also better because it stretches the incision less. Stretch damages the incision more than an incision length.
Are there different techniques to this procedure? Like, what are the instances that it would be used, and then different instances where it may not be able to be used?
I would say that we all start out with a minimally invasive concept. For example, when we both started, the kneecap was always folded over. But we've learned that not folding it over, just bringing it to the side, is actually better for what we do. Some people, however, it just folds over because that's the way their tissues come out. So we start off minimally invasive on every single patient, and we increase the amount of our invasion depending on what we need to do for the specific anatomical constraints of that patient.
Okay.
We do what we need to do for you. So that's kind of in layman's terms. So in terms of whether your incision is the smallest or the largest, I always tell people this is really about your recovery. And we really want to make this easy for you. If a small incision works, if it doesn't change what we do, it's going to be a tiny incision. If there are needs, whether it's deformity, whether there are skin issues, people have had previous incisions, all of that, we look at that. And we sort of tailor the surgery to each individual patient. And that's what you should know. So, and those are questions I think that also you should feel comfortable asking a surgeon when you approach them about having surgery. What about minimally invasive surgery, and how does it relate to me? Do I have specific things that will change that? That's also very important because there is no one size fit all for anyone.
If you think about the undercurrent of what we've been talking about, it's about giving the patient a sense of independence and control. And that allows you to get better because you're in control of your progression. A very important part of that is physical therapy, the patient doing what they need to do. Because the therapist can't do your therapy, only you can do your therapy. What are your thoughts on that, Michael?
So what I commonly tell people is, I'm going to do a third of your operation. That's the surgery. It's probably the part that makes you most afraid, but that 70% of the operation is yours, and that is with you and the physical therapist. Because I think that you have to realize, a knee replacement, we're sort of cutting your knee apart, putting it together again. And then, after that, it's between you and the physical therapist to get up, get moving, get bending, and that's such an integral part. If you don't bend your knee, the body's just going to form scar. Everything's going to be stiff. It doesn't matter what kind of job has been done. It's going to be a poor outcome. But with movement every day, the body breaks that scar. The body begins to recover. And eventually, the body stops laying down that scar. It's natural for people to be swollen after surgery. The body has muscles, and part of those muscles, their movement, is to help that fluid circulate. So you break up scar, you circulate fluid. All that's on your pathway to recovery. And as time goes, you go from immediate post-operative pain where you have needs for medications to support you, and you lessen that need for post-operative pain medication. And all of that is a natural progression toward recovery.
Expectations are really important. What we do to the tissues are really traumatic, and your body is going to respond to that like it responds to any trauma, with swelling and black and blue. And that's going to grow a little bit more every day, and 1 week from surgery, you can have swelling from the groin all the way to your toe. You have a big, fat, swollen foot, and this is just a normal part of gravity taking the fluid from your knee down where gravity takes it, to the foot. So expecting that is important. That's not a bad thing. That's part of recovery.
So what do you tell your patient who comes in, let's just say your average 40 to 45, 50-year-old patient, maybe 50, 60, nice, healthy person who has arthritis, that has a job that they want to get back to, 9 to 5, and they need a knee replacement. And they have no real medical issues, maybe blood pressure and pre-diabetes, like most of America, could lose 10 pounds. And when am I going to get back to work, doctor? And what does recovery mean to you after knee replacement?
So 2 big questions there. First, recovery. Recovery is variable, right? Somebody that was playing doubles tennis the week before is going to have a faster recovery than someone that's basically in a wheelchair, because their body, not just their knee, but their whole body, is just not functioning the same. So that's issue number 1. Issue number 2 is you will get what you put into it, right? You will reap what you sow in terms of your recovery time. People that have a very physical job, laborers, construction workers, it's going to take them 3-4 months to be able to really lift 100 pounds with that knee. Surgeons, it's going to take 3-4 weeks just to be able to go to work and not be overwhelmed by the pain and the swelling. So it's really important to have an appropriate expectation. This is a lot of surgery, even with minimally invasive techniques. And your recovery will be progressive, but it won't necessarily be fast.
So I like that word you use, progressive. So I give my patients a 3-tiered recovery. And it may or may not be right, but I think it makes them think. It's a provocative response. So I tell people that your first recovery is going to occur the day of surgery. For those of you who've never had surgery or minimal experience, when you come out of the operating room and you wonder, despite what we've told you, what have we done to you? Do my legs work? Am I going to be okay? And generally we take care of that the first day, because many people will walk, they'll stand, they'll dangle, and they'll realize that this is going to be okay. They're going to be okay ultimately. They have a road to go down, but they're going to be okay. The second phase of recovery that I like to think about is return to sort of normalcy. We use the term in medicine, activities of daily living. That means kind of doing the things that we do every day. And that, I think, is going to occur over the few weeks after surgery, 2, 3, 4. And that is sort of going up and down stairs, being comfortable in your own environment. And I think that up to that period of 6 weeks, you're building toward that level of comfort. And then I like to think of the third phase of recovery for those people who do extra things, and that is golf, tennis, or whatever. And usually sometime about that 3-month period is when people begin to get to that. So that's how I explain it to my patients. What are your thoughts? How do you think about recovery schemes?
So in general, I tell patients, don't expect to do anything truly laboriously physical for 3 months, because that's when scar tissue is really starting to mature and beginning its secondary remodeling to get really strong. So many people are able to get on an exercise bicycle within a week or two, but not on an outside bicycle for a month or two, because then you're including balance and the risk of falling into the mix of what you have to consider. Most of my patients, if they go home on Wednesday, by the weekend they're thinking, okay, maybe I want to go out for lunch. And then they come home and they're exhausted and they need to take a nap. And one of the things we both agree on is listen to your body. If your body says take a nap, take a nap. If something really hurts, maybe you shouldn't do that.
You know, I think that there's something to be said here, minimally invasive or not. This is a big operation. So, and the other word that you used early on is expectations. So, this is New York, and we like things in a New York minute, okay? So even though people are doing well, I often tell them, don't be a victim of your success. Listen to your body. I'm glad you're doing well, but you can still get tired. Have a moment, pull back, rest. Give your body that chance it needs to heal. And that's probably more important than any expectation. If you're doing well and your body says, hey, this is a day I need to slow down, you kind of do that. And it's not a loss. It doesn't set you back. It probably puts you ahead.
Also, let's get down to real basics. You have to be good to your body. So before the surgery is not a time for donuts. That's a time to really think about the quality of the material that you're ingesting. It should be good protein, good veggies. Fat, a little fat is not bad. A little carb is not bad. A lot of anything is bad. So it's a time where you can reboot and reassess, okay, what am I eating? What is its quality? And how can I make myself stronger both before the surgery and after surgery? Because if you don't eat well, your body will break down the proteins in your muscle to create new tissue to heal. So the better nutrition you give yourself, the more you're sparing your own body in your recovery process.
Absolutely. I agree with that. The time to prepare for surgery is before surgery. Whether it's nutritionally, whether it's preparing your house, setting up for things, whether it's preparing, having family members to come in, whether it's thinking about activities, just kind of strengthening. You don't necessarily need to go to a physical therapist. What kind of physical strength am I in? Those are times or preparations or thoughts that you can do sort of to optimize yourself for surgery. And I think that's very important and can't be overemphasized.
People ask me sometimes, what exercise is good before the surgery? I say every single one. Anything that you can do that keeps you functioning is better, because the better state of health you're in before the surgery, the less bumpy your recovery will be afterwards.
And for those people that need to lose weight, maybe a little bit of weight is fine, but again, it's not the time to go on a wholesale diet and starve your body and to have your body depleted of nutrients and then to have a surgery and to have your body need these nutrients and there's nothing there. So a balanced approach to everything, and I think that it's important that you integrate your internal medicine doctor, your primary care doctor, work with us, and think about putting yourself on the best platform for recovery. And all of that makes your chance for a good outcome best.
Here's an important question. Now that we're doing this minimally invasive surgery, do you think that we should do more bilateral surgery? That's a trick question.
So, again, we're back to that New York minute, and I happen to be pretty conservative. So I tend to like to do things smaller and better, but my rule, that's a great question, so I'm going to answer you with a question. Who's the candidate, or who's my ideal candidate for bilateral surgery, minimally invasive or not? So those people that come in and they can't differentiate which knee hurts, and they're both independently so painful, then I tell them those are people, if your medical condition will allow,
that's a big if,
that are good candidates for bilateral knee surgery. If you come in and you have left or right knee pain that is the preponderance of your pain, and the other one doesn't hurt, but why don't I just get the other one done because? That's not a good indication. Because surgery is surgery, and it carries a list of risks, and we happen to do a lot of them here, and we're pretty good at it. But surgery has risks. So I tell people if you don't need it, don't have it. So the answer to your question is, when someone comes in my office and can't differentiate, or if they have a deformity that is so bad that it's going to hinder their recovery, then those are people that I indicate for surgery. And I make it clear to them that they need to clear the medical muster, they need to be, their age needs to be appropriate, their health needs to be appropriate, and the complexity of the surgery, in other words, it needs to not be so complex that it's going to jeopardize, doing the other side, that we can proceed with doing them. And I also warn every patient that I'm going to do bilateral surgery on that I may not do the other side. If for some reason in my judgment, doing the other side jeopardizes my outcome, we can always do it 3 months later.
All surgical decision making is a balancing of pros and cons, right? Of the likelihood of benefiting or the likelihood of harming. And there's always a likelihood of harm. So there's certain criteria. For example, men over 70 with underlying heart disease are absolute no's. Our studies performed here at Special Surgery have demonstrated that that cohort of patients is uniquely at a higher risk of having a problem with bilateral surgery compared to do one, wait at least 3 months and do the other. And so it's all about risk stratification and choosing the best choice for that individual patient.
So we've only got a few minutes left, and might be a good time to kind of reflect on where we started again. So we're here really to talk about minimally invasive surgery. And both of us have done this for a number of years, and we've seen where we've come. When we started, incisions were long. We did big incisions for big surgery. And I think that what's happened over the last 20 years, we've refined the operation and our ability to do it. But we've not only refined our decision-making about who gets surgery, how we do surgery, but there are things surrounding it that make us better. Some of those things.
Doing good surgery is about having good people around you. One of the special parts of special surgery is that every person that is here is focused on quality in musculoskeletal care. Our anesthesiologists are expert. Our nurses in the OR, our surgical techs, help us perform the surgery precisely, reproducibly. And you can't take away, show me who you're with and I'll show you who you are. If we are great, it's not just because of him or me, it's because of all the people around us. And I'll point out, when my grandfather was injured, I asked him to take care of him.
The great part about being here, and I tell people all the time, is that there are people you can depend on that help you, that do just one thing all the time. And they're so good at it. If it's your knee, the nurses here take care of thousands of knees every year. And they recognize what is needed to make you better. Whether it's your back, take care of backs. So it's a team, and the team makes this boat float that we call special surgery and helps make us do what we do. And it's very important.
We had one last question. It was from Francine. She wanted to know, is the recovery period for hip replacement the same as for knee replacement?
It'll be interesting. I'm going to answer, and I'm going to ask Jose to answer because we may differ.
Mm-hmm.
I personally think that the pain, in my experience, that I've seen my patients who have hip replacement, it is less. And I don't understand how we do what we do, and people wake up and they feel a lot better. I think that the people who have knee replacement typically have more pain. And one of the issues is people who have hip replacement just have to get up and walk. Now they have precautions, it's not that simple, but they have to get up and walk and learn to walk. People who have knee replacement have pain issues, and they have to not only learn to walk, they have to bend. So it's a much more complex recovery.
That's really important to understand. The answer to the question is that it takes the same amount of time to get better, but I'm going to use a New York colloquial term. It's more sucky with a knee than with a hip. That's just the reality. It's a much more painful, difficult procedure because the patient has to actively do something that hurts them. That is, bend and straighten their knee. A hip, when you walk, it really doesn't hurt, but a knee does hurt. And if you don't do this, you won't get better the same. And that's why our focus on patient active engagement before, during, and after the surgery is so critical.
People who come back at 6 weeks after a hip replacement, by and large, are smiling. And they will often tell you, I'm so happy I had this, even at 6 short weeks after. People who have had knee replacement, they say, I'm not sure yet. And it takes a little while longer. They eventually get there. But we have this concept called the forgotten hip or knee. And that means you've forgotten that you had that. And it's much more common with people who have had hips, that they'll forget about their hip. People with knees may be satisfied with their knees, but it's less common that they have forgotten that they had a knee replacement. And that kind of sums up the answer to your question. So thank you all for this. I hope you were able to get some good answers and understand that minimally invasive surgery doesn't just mean a small incision. There's a program, there's a team of people that we have to utilize to make your recovery better, not just making a small incision. It goes with the surgical technique, the nursing care, the pain management, everything that surrounds getting you better.
But most importantly, it's about you, understanding that you are our partner. We can't do it without you. You have to be part of it, engaged, and wants to get better. If you want to get better, we will tell you what you need to do, and you'll get better. Thank you very much.
So keep it moving.